Hey everyone, welcome to the Baltimore County EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesiologist and critical care physician at Hopkins. I'm an active member of Pikesville Volunteer Fire Company, and I have the honor of serving as one of the assistant medical directors for Baltimore County Fire Department. On behalf of Dr. Jeff Nussbaum and the Medical Director's Office, Chief Nats, EMS Office, EMS Training Academy staff, and Captain Lenny Stewart, thank you for what you guys do every day to help our community, and thank you for your dedication to lifelong learning. Big shout out to Ashley Brooks, a young member of Pikesville, who's going to be helping us manage the platform tonight. Later in this session, in the training, Ashley will put a link in the chat. Click on the link, fill out some information, get your MIM CEUs. If you have any challenges with getting your MIM CEUs or have questions about past participation in classes or how to find your MIM CEUs, please hang on with us after the training, and we'd be happy to help you and answer any questions that you have. So super delighted yet again to have with us again Dr. Laura Bontempo. Dr. Bontempo is an associate professor of emergency medicine at the University of Maryland School of Medicine. She received her medical degree from Northwestern University in '94 and subsequently completed an emergency medicine residency at Northwestern Memorial Hospital. She spent 5 years at Harvard University as the Associate Emergency Medicine Program Director, and then was recruited to Yale University to become the Emergency Medicine Program Director, a position she held for 7 years. Dr. Bontempo completed a Master of Education degree with concentration in health professional education at the University of Illinois. She has received numerous teaching awards in emergency medicine from Harvard, Yale, Northwestern University, and University of Maryland. She's received national teaching awards from both the American Academy of Emergency Medicine and American College of Emergency Physicians. Dr. Bontempo has published in multiple emergency medicine textbooks and journals and has lectured nationally in the area of cardiology and otolaryngology. I also noted, I was talking to Laura before the conference started, 4 years ago, she gave a similar talk about tracheostomy emergencies when we were holding in-person sessions at Pikesville Volunteer Fire Company, and that has the most views out of 150 videos we have recorded at 35,000 views. So please feel free to check out the library of videos and find Laura's in-person presentation at Pikesville. Yeah, it was quite good. I had a chance to see some of it again tonight. So again, Laura, thanks for coming back. We super appreciate you.
You're welcome, and thank you so much for having me, and thank you everyone for taking your time this evening to join me. I do wish that we were in person. That was a lot of fun. I don't get to hang around fire stations very much, and I think it's kind of a fun place to be, but here we are virtually, and I'm really glad you took the time to join me tonight. We're going to be talking about critical must-know ear, nose, and throat halo events. So the first question is, what is a halo event? Well, that's a high acuity, low occurrence event, something that when it happens, you have to know how to manage right away, no time to look it up, but not something that happens very often. So before we jump into ENT, we're going to look at this pretty disturbing slide to look at. Anyone remember this? This was just in the news just a few weeks ago, and this was when the Japan airliner crashed into another plane. Now, how many people do you think got off of this plane alive? Well, the answer is all of them did. Every single person on this plane got off of that plane alive because that flight crew had trained and trained and trained for these halo events. And that training for this halo event saved lives. And you guys are in the business of saving lives. So today we're going to talk about some halo events that you need to prepare for when they happen. We're going to talk about 3 halo events specifically. First, posterior epistaxis. Second, tracheostomy bleeding. And third, oropharyngeal hemorrhage. By the way, cameras on, cameras off, whatever you feel comfortable with. But if you have a question, please feel to jump in and interrupt me. It's kind of hard to monitor people watching while I'm actually talking to you. So feel free to interrupt me with a question. That's completely fine. If you want to put something in the chat box, that's fine too. I love to hear your experiences with these things. All right. So first, we're going to start with posterior epistaxis. Now you may be thinking, well, posterior epistaxis, I mean, epistaxis isn't a halo event. I take care of epistaxis all the time. I've had epistaxis. It's not that big of a deal. And 90% of the time, you're absolutely correct, because 90% of the time, epistaxis is indeed anterior, and you give a little squeeze to the front of the nose, some good compression, maybe a little silver nitrate, some cautery, and it's solved 90% of the time. But 10% of the time, in that halo event, the bleeding is posterior. And when you squeeze anteriorly for a posterior bleed, all you're doing is blocking the exit of the blood, but you're actually doing nothing to affect the blood that continues to pour down posteriorly through the posterior oropharynx, often swallowed, oftentimes vomited by your patient, oftentimes presents as hematemesis, even though the etiology is truly posterior epistaxis. So why? What's the difference? Why are these ones in the back so much worse than the ones in the front? Well, if you look at a little anatomy, most epistaxis is from Kesselbach's plexus, and that's in the front part of the septum. That's a part that's prone to trauma, digital trauma, as one might euphemistically say, drying of the mucous membranes, any of those things. But if you look in the back here, there's a posterior ethmoidal artery and the sphenopalatine artery. Those are non-compressible arteries. So now you have a nosebleed, that's a non-compressible arterial bleed. Nothing sounds good about a non-compressible arterial bleed, and these are not good either. Phrased another way, if this is a anterior bleed, then that's a posterior bleed. This is the difference. Anterior bleed, yeah, maybe there's some blood. Maybe your patient called 911 because they're kind of freaked out that they're bleeding from the nose, but it's really not that big of a deal. Posterior bleeds are high volume bleeds that are very difficult to stop, or can be very difficult to stop. So first thing, if you come across a patient and you think there's a posterior bleed because they are squeezing that nose, yet they're still high volume, they're spitting up blood, you look in the posterior oropharynx, there's still blood coming down in the back of the oropharynx, despite them squeezing the front of their nose, nothing's coming out the front, still going down the back. Maybe they follow it up with some vomiting of the blood that they've swallowed. You have identified a potential posterior bleed. It's okay if you overcall it, not a problem. Better to worry about the more serious pathology. First thing you need is your PPE. These things are messy, right? Patients are bleeding, they're coughing, they're sputtering. You have to get up close to them. I don't want you to get a blood and body fluid exposure. So please get your eyes covered. It always amazes me. Sometimes I see medics roll in with patients and I think, where is your eyewear? Protect yourselves. So please make sure you keep yourself covered. High risk for you getting a face full of blood. And then, of course, you're going to start an IV on this bleeding patient. I know you all know that. That's not news to anyone. But then what can you do next? Well, interestingly, ice to the palate actually reduces the blood flow to the nasal mucosa by up to 24%. Pretty phenomenal. 24% decrease in blood flow. That'll gain you some ground when someone's bleeding. So if you have a response to someone's house and they have ice, grab some ice from their freezer. Have the patient hold it in their mouth. Don't swallow it. Don't chew it. Just hold it in their mouth to cool down the palate specifically. If it's a kid, you respond to a house or a school and there's a popsicle around, give the kid a popsicle. And specifically have that popsicle be pointed up towards the superior portion of the mouth, the palate, cooling blood, decreasing blood flow to the nasal mucosa. So that's the way that ice works. Here's how ice doesn't work. I don't know why we ever came up with these ideas. Who thought that putting ice on the back of the neck somehow is going to affect the bleeding from the nose? I don't get that. It's a very common thing that people do. At least putting ice on the nose maybe might make some sense to me, but that doesn't work either. So neither of those things work. Don't do it. I don't think that you would, but if patients have that going on when you arrive, just take it away. And if there's ice there, put it in their mouth instead, because there's a chance that actually can help you out. So maybe you've slowed down the bleeding a little bit. Maybe you haven't. What's the next thing that you're going to do? Well, you need to get your suction, right? You need to get your suction ready. Here, you're going to suction out not so much from the nose. You don't want to suction that because if any clot is forming, you do want to leave that alone, but you probably need to suction out the airway, right? These patients are swallowing a lot of blood, maybe coughing on it, hopefully not choking on it, but feel free to suction the oropharynx. You're not going to disrupt any clot that's useful to you when you suction the oropharynx. Suctioning the nasopharynx doesn't really buy you anything. It doesn't help. And if any clot is forming as you slow the blood flow because you cooled the patient's palate, you'll actually be working against yourself. So don't do that. As far as positioning, lean the patient forward. The more blood that comes forward, they don't have to squeeze their nose, right? Patients squeeze their nose because it sort of makes them feel better, like they're doing something. But if it's a posterior bleed, squeezing the nose doesn't do anything. And taking that blood and pushing it posterior down to the esophagus, hopefully not, but down towards the trachea, or specifically, you don't want it to be. So transport that patient sitting up, even leaning forward. And then you get to transexamic acid. This is the new duct tape of medicine, right? It's supposed to fix everything. I asked about this. I'm told that some of you have it on your rigs and some of you don't have it on your rigs. So if you have this, this is wonderful. It really helps with clotting, really helps with bleeding. And the beauty part about tranexamic acid is you can atomize it, you can nebulize it, you can give it IV, you can give it IM. If you have that medicine, there's a route to get it into the patient one way or the other. And the other beauty part about tranexamic acid is that the dose, atomized, nebulized, IV, IM, it's the same. And that's 500 milligrams. Now, for you who are out there are really precise, you could say, but I was told I could give up to 1 gram. Well, yeah, you can give up to 1 gram, and that's fine if you want to remember that. But again, we're talking about halo events. So I want you to memorize things that are easy to memorize, keep it as simple as possible, because when that low occurrence event happens, you have to go into high acuity mode and be able to recall as much as you can about how to manage it. So 500 milligrams, no matter what route you give it, that's how you use tranexamic acid. If you have it, use it. Otherwise, for those of you who don't, or even if you use tranexamic acid, I know that you have combat gauze. Well, at least I asked, and I was told that you have combat gauze on your rigs. You can use that. The key here with combat gauze for posterior epistaxis is that if you pack the front of the nose, you're not going to have any compression on those posterior vessels. So here's where it gets a little tricky. You have to pack the nose as best as you can with a combat gauze as posterior as you can. So yes, is it going to be uncomfortable for your patient? Absolutely, it's going to be uncomfortable for your patient. But the farther back you're able to get that gauze, while of course leaving some coming out of the front of the nose, so there's not a risk of aspiration. You never want to pack it back so far that you don't have anything on the outside that you can grab out if you need to, if your patient starts to choke. That's the key. You've got to get posterior and pack away. The more you're able to get in there, the more chance you have of tamponading that vessel. Compact gauze is a good option. But what's another good, really low-tech option? Well, we're going to go really low-tech here. A tampon. Tampons work, right? They absorb blood, they fill space, they can tamponade a bleed. So if you have a tampon on the rig, or if you don't, it might be worth having one. You can insert that into the patient's nose, and look, it has its own aspiration protection by having a string on the end of it. So you can push that as posterior as you can into that patient's nose. Feel free to put a little lube on it if you'd like. The key here is rapid insertion, because as it comes in contact with blood, it's going to expand. That's going to get uncomfortable if you're trying to move it as it's expanding. So get it in as quickly as you can and as posteriorly as you can. And just in case you think this is odd, which it is, and in case you think I'm making it up, this is from the World Cup. A Canadian captain played the World Cup with a tampon in his nose. Now, why at the World Cup there weren't proper packings for epistaxis, I have no idea. You would think at that level someone would think to bring one of those along, but they didn't. And the tampon was handy, and that's what was used for this guy's nose. Now, clearly, this is I can tell just by looking at the thing that this is anterior epistaxis because so much is hanging out of his nose. For posterior epistaxis, you would need to push that as posterior as you possibly could. So multi-use device right there, guys. Use a tampon for tamponading bleeding. And you can also cut these longitudinally for a kid if you need to make it smaller, thinner, essentially. All right, so what would I do when the patient gets to me, when you get that patient to me in the emergency department? Well, I have this beautiful thing called a posterior epistat balloon. It's a posterior epistaxis balloon. No endorsement of the brand name whatsoever. That just happens to be the term that I'm familiar with. And this is a balloon that, as you can see, has two balloons. It has a posterior balloon, which is the smaller one, and an anterior balloon, which is the bigger one. The diagram below, you can see you insert this up to the hub. Then you inflate the posterior balloon with about 10 cc's of air. You pull it forward so it really sets back there and tamponades against those potentially two bleeding posterior arteries. And then you slowly inflate the anterior one to add additional compression to any arteries that may be bleeding anteriorly and to keep the thing in place. That's what I have in the emergency department. This thing can be a life-saving device for someone who has posterior epistaxis. If you were working in a resource poor, if I was working in a resource poor area, if these were out of stock on backlog, which so many things are these days, I can go a little low tech. And that is use a Foley catheter. Literally put a Foley urinary catheter into someone's nose, look in the back of the oropharynx. When I see the tip of the thing, start to inflate the balloon and then put traction on it and pull it out until it sets in the back of the nasopharynx, again, tamponading those posterior vessels. So there's high tech and low tech right there. Anything you can do to get pressure on the bleeding arteries. So I know that in your rigs, you don't have these. You don't have the balloons, but you do have these. And this is where I have an asterisk, because this is just my MacGyver opinion. This has never been tested. I'm not suggesting that they're randomized control trials, but I would do this if I thought it was going to save a patient's life. Put a 6.0 or smaller endotracheal tube in through the nose. It actually doesn't matter which side with these posterior bleeds, because the balloon essentially goes behind the septum. I would look in the patient's mouth until I just saw the tip of the endotracheal tube. When I saw the tip of the endotracheal tube, actually probably the bottom of the balloon, I would slowly start to inflate that balloon and see if I could gain tamponade of those arteries with that balloon. Again, not field tested, my opinion. I would have no qualms doing this if I thought someone was going to exsanguinate as I was transporting them to definitive care in a hospital. Now, if you get to the hospital, we put the balloon in and it's not working, or even if it does work and holds off the bleed for the moment, in the end, these patients go to IR or to the OR. That's the level of bleeding here. The patient needs to go emergently to interventional radiology, where they'll have an embolization done, or they need to go to the operating room where they simply need to have their vessels ligated. That's the halo of posterior epistaxis. All right, we're going to move on to massive tracheostomy hemorrhage, but I'm first going to throw this back to you guys. Has anyone have experience they want to share with someone who really had massive epistaxis and posterior epistaxis? You know, people tend to be quiet on Zooms, but if you had an experience, you want to tell me how it went, good, bad, or otherwise, what you did, certainly love to hear it. All right, maybe at the end, you guys can think about that. Maybe get unmute your mics as we go on. Second halo we're going to talk about, high acuity, low occurrence events, is massive tracheostomy hemorrhage. So here's a tracheostomy. Here's a tracheostomy with blood. Doesn't look that bad. That's not massive hemorrhage. There's hemorrhage. Clearly there's blood, that tracheostomy, but it's not massive hemorrhage. So maybe the patient calls you, there was some bleeding, it stopped. They say, sorry guys, didn't want to bother you. I'm sure you're busy. I just panicked. I saw the blood. It stopped. I'm all good now. I'm refusing transport, or thank you for your service. Go take care of someone who's sicker. And I want you to really pause when you're in that situation, because the truth is that any bleeding from a tracheostomy simply must have the source identified, because these are high-risk bleeds. And the source can be identified in a multitude of ways, with eyes, with angiography, or with endoscopy. But really, you need to look and find out where the bleeding is. Now, why? Why is that? Bleeding stops, we generally don't worry about it, right? Someone cuts themselves, the bleeding stops, we think it's all good. This is different. This is different because 50%, half of major life-threatening tracheostomy bleeds have a sentinel bleed. Half the time you get a warning shot. So if your patient calls and they get their warning shot of a bleed that then stopped and they say, I'm fine, you really need to impress upon them to the best of your ability. I know some people are going to refuse no matter what you do, but you need to impress upon them to the best of your ability that this was a warning, and we have to make sure that the big one, the big bleed, is not coming down the pike, and the source really needs to be identified. Now, when I talk about this big one and warning shots versus massive bleeding, here's what I'm talking about. We're talking about a tracheoinnominate artery fistula. This is a high pressure, high volume bleed. And when these happen, not the sentinel bleed that stops, but the bleed that doesn't stop, there is a greater than 95% mortality. More than 95% of people are going to die who have one of these. So if your patient was lucky enough to be in that 50% where they had a warning and the thing stopped, you really need to impress upon them that I really need to start this IV on you. I really need to get you to the hospital. It could save your life. So what is a tracheonominate artery fistula? Well, let's look at the anatomy here. So you can see the trachea in the back and the aortic arch in the front, and the aortic arch has those 3 blood vessels that branch off it. The one to the right is the innominate artery. Now, there's kind of a design flaw here. Not how I would have designed the human body, but funny, no one asked me about that. The innominate artery crosses over in front of the trachea. And we all have some anatomical variation. No two people are made exactly alike. And sometimes that innominate artery crosses a little higher. Sometimes it crosses a little bit lower. Sometimes it puts a little pressure on the trachea. Now, we're all built that way, and I'm not bleeding out of my neck. I'm not bleeding out of my mouth. But the difference is when you put a foreign body into the equation, and a foreign body with a balloon. And if that balloon is inflated and causing pressure on that anterior wall of the trachea and has pressure necrosis and a little bit, then hits that tipping point where it breaks through into the innominate artery, you now have a high volume, high pressure first branch off of the aorta system hooked into your airway. That is not going to be a good combination. So if you are unlucky enough to have this happen on your shift and the bleeding is ongoing, or even if the bleeding stopped, again, I cannot emphasize this enough, you need to get your PPE on. These are pulsatile bleeds that can spray from the patient's trachea. I want you to protect yourself. And then, of course, you're going to get suction. Now, I'm told that you have suction in the rigs and you also have portable suction. If you think you're dealing with one of these, get them both ready because you're going to need them both. Then, and honestly, if you remember nothing else about bleeding from the trachea, here's the thing I want you to remember. Key elements for halo events. Use a balloon, the balloon of the patient's airway, in your favor. If that tracheostomy is a cuffed tracheostomy and the balloon is deflated, inflate that balloon. If the bleeding does not stop when you inflate the balloon in an attempt to tamponade that hole, to block that hole that's between the innominate artery and the trachea, inflate the balloon some more. These balloons can actually hold up to 50 cc's of air, and you can look at the change in the appearance of that balloon on the tracheostomy. It's wider, it's taller, there's more pressure behind it, and 85% of the time, not bad odds, that's going to stop or at least control the hemorrhage so you can keep that patient alive until they get to the hospital. Now, what if there's no balloon? A lot of tracheostomies are uncuffed. Well, the good news is there's lower chance of having a tracheonominate artery fistula if there's no balloon, but they still happen. They certainly do happen. So what I'm going to tell you is going to be completely counterintuitive, and I've not lost my mind. I am telling you, take out the tracheostomy if there's no balloon on it. It is not helping. It is only hurting. Yes, I'm telling you to take out the airway of someone who's bleeding into their airway. Don't tune out. I promise there's a reason behind this. You need to get something in there that has a balloon. So if you can take that tracheostomy out because the patient is still bleeding and get in an endotracheal tube, usually 6-0 endotracheal tube will fit through most tracheostomy stomas, smaller if that's what fits. Put it in what fits. Put it in just a few centimeters. Remember, you're not intubating. You just want to get that balloon fully into the trachea and then inflate that balloon and see what that does. If that does not slow down or stop the bleeding adequately, inflate that balloon some more. Again, up to 50 cc's of air can go into these balloons, and look at the difference in the shape of those balloons, right? One is going to cover much more territory and do a better job at attempting to tamponade. And again, remember, 85% of the time, that's going to stop the bleed, or at least if you don't get full hemostasis, slow it down enough so that you can keep that patient alive until they get to a hospital where they can get to the operating room. If you're in this unfortunate situation, the patient doesn't maybe had the sentinel bleed, didn't call an ambulance or didn't go to the hospital, you're here with this massive tracheonominate arterial fistula bleed, and you put the balloon in and you're in that 15% and it's just not working, There's one truly heroic maneuver left. I hope that none of you ever have to do this, but it's at the bottom of the bag of tricks. And that is called the Utley maneuver, where you would literally put your hand into the patient's stoma, and you can see you're going to try and compress that artery between your finger, which is inside the patient's airway, and your thumb, which is outside the patient's airway. Now, if you do this and the patient can't breathe, then you're going to have to hold essentially pressure as you guys are driving along as quickly as you can until the patient can no longer tolerate it because of hypoxia or whatever it may be. Remove your finger, let it bleed, and repeat until you get yourselves where you can get back up into a hospital. The other option is if you got that endotracheal tube in, you can also put your finger in and go proximal to the balloon. So the balloon isn't tamponading it. You can advance that endotracheal tube and get your finger proximal. Now, I didn't make this graphic. I certainly suggest you wear a glove if you ever have to do this, but you're going to want to put your finger in there and also have your thumb on the outside for compression. That is a heroic maneuver. That can potentially keep someone alive while you are driving, and I mean driving fast and giving us warning ahead of time that this is coming our way. And least you think I am being overly dramatic here. Here is something that I pulled off of social media. This is from Dr. Shirley Myers, part of EM Docs. And yes, you can read this whole thing, but I'm going to give you some highlights here. She says that their patient had pulsatile bleeding from the mouth and the trach. That's not going to be a good sign. The patient was on 3 pressors and received 42 units of blood. 42 units. That's more than triple your body's blood volume turned over. You can see all the suction containers. The patient, she tamponaded the bleed with a cuff of the trach. So that worked. She held off the bleeding by cuffing that trach. And then that patient had to get an ambulance and be transported to a tertiary care center where they could get to the operating room. And she sums this all up. I love the way she sums it up. I need a new pair of scrub pants. Now, did she need a new pair of scrub pants because she got blood on her from the bleeding tracheostomy? Maybe. I don't think that's why she needed a new pair of scrub pants. I think I would need a new pair of scrub pants if I gave my patient 42 units of blood and had them on 3 pressors before I got the bleeding stopped. But this does really happen. It does not happen a lot, but it does happen. So truly a halo event. Again, untreated, the patient's going to die from this. If there's not someone on the scene in short order who knows what they're doing, patient's going to die from this. The expectation, unfortunately, is that the patient will die from this. But if you get there and you know what you're doing and you remember this and you think balloon, if I just remember the balloon, 85% of the time, you're going to be able to slow that bleeding down or even stop it and get that patient to definitive care.
Hey, Laura, one of the attendees says, our protocol states that patients with an unstable airway go to the nearest ER. Should we favor a trauma center for this situation?
Not a trauma center. This is any surgeon can do this. Any place that has
Closest ED.
surgery.
Right.
Closest, absolutely, because these patients are bleeding. Yeah, I always, that's a question I get asked. I always find it so difficult to answer because when you're in the back of your rig with your patient, making that decision about turn left or right, better center there, closer center here, I don't envy you being in that position. That's always sounds tough, but this is not as much of an unstable airway as hemorrhage, as patients going to die from exsanguination, and you get them to the closest place you can get them to. They can always be, if it's like, just like what happened in this EM Docs post, the doctor stabilized, stopped the bleeding, got the patient resuscitated, and then shipped them off to another facility. All right. We are going to move on to oropharyngeal hemorrhage. So again, these things happen. They are high acuity, low occurrence, but to make sure you know that, yes, this can happen at any time and it can happen to you, I want to share this with you. This is a box call. This is the sound that I can hear. I swear I can hear this from my house, even though it goes off at the hospital, because I'm so attuned to this. Take a listen.
Baltimore County Paramedic 5 and Officer Chile, we have a 10-minute ETA on board. We have a priority 1 56-year-old female coming from home. She advised She had tongue surgery done a week ago.
Oh, sorry. Oh, it rerouted. I'm sorry.
Yes, Baltimore County Paramedic 5 and Route 6 Chile with a 10-minute ETA on board. We have a priority 1 56-year-old female coming from home. She advised she had tongue surgery done a week ago at your facility, secondary to removing a cancerous portion of her tongue. She was held there for a week, discharged yesterday, perfectly fine. About 30 to 45 minutes ago now, she was trying to put water through her feeding tube, at which point copious amounts of blood started coming up from her mouth. There was blood all over the bathroom, and her mouth is full of blood. It is not including her airway. She has no difficulty breathing. She is ANO ×4 with a GCS of 15. Complaining of some mild stomach pain and some lightheadedness. Pressure was initially 99/60. We're currently 71/49. We do an 18 gauge in her right AC. It was fluid going wide open. We will see you in less than 10. Any copy?
Was that any of you on that recording? It certainly could have been. So that patient's in your rig. I have 10 minutes to prepare for this patient in hemorrhagic shock, and you have 10 minutes to keep that patient alive until they get to the hospital. This was not that long ago, actually. So why does all this happen? Why are we talking about all these ENT halo events that involve blood and a lot of bleeding? Well, let's jump to anatomy for just a quick second here. Won't be there long, I promise. Look at this. This is the arterial supply of the head and neck. These are very vulnerable areas, and it's highly, highly vascular. You bleed, right? When patients have problems in the head and neck, they bleed, and they can bleed a lot. And bleeding begets more bleeding. So sentinel bleeds are really key things to pay attention to. For patients who have post-tonsillectomy bleeds, massive events, high volume post-tonsillectomy bleeds, a full 41% of them will have a sentinel bleed. They'll have bleeding that stopped, and the recurrent bleeding is the massive event. For patients with recurrent head and neck squamous cell carcinoma, 50% of them have a sentinel bleed before they have the major event. If they bled once, they have a 50% chance of bleeding again at a larger volume. Tracheonominal artery fistula patients, we already talked about that, 50% of them will have a sentinel bleed. You have to pay attention to that first bleed, even if it stops. Don't let a patient convince you it's no big deal. Don't let them do that. Do the best you can to get them to the hospital. You may save their life. And as far as patients with head and neck squamous cell carcinoma, 13% of them will have a major bleed. That is a huge percentage. 13% of patients with oropharyngeal squamous cell carcinoma will have a major bleed at some point along the way. What are the risk factors for this happening to patients? Well, if someone's had surgery, right? If they've had surgery, we've disrupted their anatomy, we've disrupted their blood vessels, we've disrupted their tissues. The chance of them having a bleed is significant. We talked about someone having squamous cell cancer. This tends to be more in the older population. Unfortunately, it seems to be moving down to the younger population more recently. And if someone has had recurrent disease. Of course, if someone is getting treated, chemotherapy, radiation, they're at risk for having bleeding. We have friable blood vessels. We're putting them on strong medications and chemo, and we're directly damaging their tissue with radiation. And then there are some other things like pharyngocutaneous fistulas and surgical site infections, put someone at risk for bleed. These tend to be sicker, older patients. Okay, you have cancer of the head and neck. It's a high risk for a bleed. We know that. You're already sick for starters. But let's change that up a little bit. What about the young, healthy patient who goes to get their tonsils out, right? This is your tonsillar bed. That tonsillar bed is fed by five arteries. And if you trace backwards, these arteries come off the internal carotid. So again, a high pressure system. When you get your tonsils out, what holds all that arterial bleeding back? Well, the Escher, right? The burn from the cautery or whatever was used to stop the bleeding during the surgery. As long as that Escher is in place and holds him fast, you are fine. But if that Escher releases before these arteries, any one of the 5 of them is fully clotted off, you have an arterial bleed in the mouth. And these tend to be young, healthy individuals. They're just having their tonsils out. What's the risk factor for this? Well, adolescents, they're the people who have their tonsils out the most. Men tend to have it more than women. Patients who snore, the thought is that with vibrations in the back of the throat, you can disrupt the Escher in the surgical bed. Patients who've had their tonsils out because of having recurrent tonsillitis, and obvious things like patients who use things that put them at higher risk for bleeding in general. Now, for any of you who might have kids who maybe need to have their tonsils out, or as an adult need to have your tonsils out, well, the risk of dying from having your tonsils out is extraordinarily small. It is a safe procedure. But if you're gonna die from having your tonsils out, you're gonna die from a post-tonsillectomy hemorrhage. That's what causes the majority of post-tonsillectomy deaths. Again, overall numbers are low as far as mortality, but within the mortality, bleeding is the #1 cause. And this tends to happen, post-op day 5 to 7. That's the highest risk period. Just when patients are home, right? They're home from the hospital, they think everything's fine. Of course, when you're on shift, that's what's going to happen. That's when the 911 call is going to come in and the patient starts to bleed. And I kid you not, I got home from my shift maybe half an hour before giving this talk, and I had a patient today with a post-tonsillectomy hemorrhage. She was a 30-year-old, perfectly healthy person, no squamous cell carcinoma, none of that. This was strictly post-tonsillectomy. She was post-op day 7, like she read the textbook, I promise you, and she came in and she brought me this picture. I just threw it in 15 minutes before giving this talk. This was her sink. If you look closely, she said, I was just sitting there, I was doing nothing, and boom, all this blood started coming out of my mouth. You can see it's bright red and clotting. There's both fast, fresh blood and blood that has been there a little bit of time to clot. Pretty high volume. Came in to see me in the emergency department, no bleeding. It completely stopped on its own. Do I send this patient home and say, you're good? Absolutely not. This was her sentinel bleed. It had to be addressed. Patient went back to the operating room. Even though she was in there texting on her phone, looking great, vital signs perfect, that was her warning shot. She thankfully had one, went to the operating room to get the operating bed recauterized. I can't make that up. I swear that happened today on my shift. So why do we take this so seriously? Well, arterial bleeds aren't good things and patients die from them. If you have a vessel erosion from squamous cell carcinoma, you have a 40 to 50% chance of dying from that bleed. We talked about the tracheoinnominate artery fistulas, 95+% chance of dying from that bleed. Post-tonsillectomy hemorrhage, again, very low occurrence, but the risk of death if you have that post-tonsillectomy hemorrhage is 35%. It's up to 35%. There's some variation depending on which study you read, but it's not small, right? That 35% is significant. So that's what we worry about. So what do we do? What do? You get the call for that patient. They have oropharyngeal bleeding. Maybe it's from squamous cell carcinoma. Maybe it's an adolescent who had their tonsils out a week ago. Well, again, I know I sound like a broken record, but get your PPE on. Again, patients are coughing, they're sputtering, they're bleeding, high risk for blood and body fluid exposure. Put an IV into that patient. Well, hell, put 2 IVs into that patient. These are large volume bleeds, put 2 IVs in. As far as medications, you see this poor little girl, she had her tonsils out, and this is actually her parents carrying her into the emergency department. Not my patient, this is a public image. You want to get an antiemetic on board for that patient, right? They're going to be swallowing blood. And the difference here is that you're going to be looking in that mouth. You're going to be working in that mouth. You don't want to trigger that gag reflex and have all that blood come back up. It's going to be all over you. It's going to be all over the patient. It's going to obscure where you're looking and just make your job more difficult. So get some antiemetic on board. Get the patient on oxygen. They might not be hypoxic. I hope they're not hypoxic, but that patient may need to be intubated. And the more oxygen, the more you can pre-oxygenate that patient, the more time you're going to have if you are doing that crash intubation in the back of your rig. Or honestly, if I'm doing it in the emergency department, I would appreciate it if you would pre-oxygenate the patient and give me those few extra minutes before the patient desats if I have to intubate that patient. And then we're back to this. Then we're back to suction. Now, here's where I want you to pause from it and think about this when you have suction, because suction is a good thing, but with oropharyngeal bleeding, suction can be a deadly weapon. If you are able to, through some of the things we're going to talk about here, get the bleeding slowed down, and the patient's airway is not occluded, You don't want to suction that patient, even if they're uncomfortable, even if they are trying to get you to do it because they look miserable. If you get clot to form, the last thing you want to do is suction off that clot. That clot is your friend. That clot is life-saving. So as we talked about with epistaxis, you're not going to suction out of the nose. You're only going to suction out of the oropharynx if you need to clear the airway. Tracheoabdominal artery fistula, you're not going to stop that. There's no clot that's going to form when your artery is connected to your airway. That's not an issue. But here, you are actually, the bleeding's from the mouth and you're looking in the mouth. You don't want to suction that mouth unless it's absolutely mandatory to clear that patient's airway. So use your suction with caution. Then we're back to this. Does this look familiar? Same thing. TXA, any route you can give it. The most effective route for oropharyngeal bleeding, including post-tonsillectomy bleeding, is to atomize it, right? If you don't have an atomizer, that's fine. Give it any which way you can. It's going to help, and the dose remains the same. 15 milligrams per kilogram for kids, max dose of 500. Can you go up to 1,000 on kids? Yes, you can. Again, trying to keep this as simple to remember as possible for your long-term memory. Just remember 500. You're not going to go wrong there. Next. Bleeding tends to stop when you hold pressure, right? If you can see the source of bleeding in this child or adult, in this patient's mouth, part of the tongue's missing, maybe they're bleeding from their tongue like our patient was, maybe it's a post-tonsillectomy, they're bleeding from the back of their mouth. If you can get pressure on that artery, because these you can actually get to, which is different from posterior epistaxis, you can maybe tamponade it yourself. If you are daring or you think your patient is cooperative and you want to try and tamponade it with some gauze on the end of your finger, that's fine. If you don't want to risk one of your digits, well, I totally understand that. That's fine too. You can take gauze on the end of a hemostat. You can take that combat gauze that you have on the end of a hemostat, put it into the mouth, see if you can get it close to the source and apply pressure. Again, this is where you want that antiemetic on board because you may trigger a gag reflex and you don't want that. You want to decrease the risk of that patient vomiting and sort of undoing the work that you're doing, making you have to release pressure and pull out of that patient's mouth. If you can get pressure on the bleed, you're going to slow it down or hopefully stop it. If none of that works, if all of this fails, think back to that diagram just as I showed you of the tonsillar bed. All of the blood, arterial blood flow to the head and neck come off of the carotids. You can, in conjunction with the other things that you're doing, try to decrease the blood flow to those arteries by simply applying pressure to the carotid artery on the ipsilateral side of the bleed. Now, you might not know. If someone had squamous cell carcinoma, they've had a resection, their anatomy might be all messed up. You might not be able to know which side is bleeding. Pick one. You're not, worst is that you're wrong. It's better than doing nothing. If a child had a tonsillectomy and you can look in the back and you can see one side's really bleeding, I could see today clearly by looking in my patient, it was her right tonsil that had been bleeding. If she had a massive hemorrhage, I would apply pressure to the right-sided carotid artery. Press as hard as I can. They have an intact circle of Willis. The other side's going to take over. You're not going to give them a stroke, but you will decrease flow, maybe decrease pressure to the vasculature, the arteries that are causing that massive bleed in the mouth. And then the airway. Yes.
One of the attendees brought up a slide or two ago, your comment about the 2 IVs for bigger bleeds. And what about the risk of thinning the blood and slowing further any clot formation? As you know, right, there's this idea that in traumas, we don't flood them anymore with crystalloid. So how do you find that balance?
I find that since you don't have, I would give blood, but if you don't have access to blood in your rig, which I assume unless you're a critical care transport, you're not going to, I've got to do what you can to maintain the pressure, to maintain cerebral perfusion. So have the second IV. You don't necessarily have to use a second IV unless the patient becomes hypotensive, but having that extra access is very much appreciated when the patient gets to the emergency department. So this way we can hang that blood through the second access while you're putting saline through the first one. Any other questions so far, Sean?
Nope, that's good.
Good. All right. As far as the airway goes, if you're in that critical situation and you have to manage that airway, this is not going to be an easy airway. Even if the patient, is otherwise anatomically fine, this is not going to be an easy airway. The patient at this point is probably in some element of hemorrhagic shock. they've swallowed blood, they have a stomach full of blood, you've given an antiemetic, but still the chance of them vomiting is there, and you're going to have reduced visibility. If you cannot get an endotracheal tube in or feel that you're not going to be able to, it's too high risk, by all means, use a supraglottic airway. It is a completely fine thing to do. And the benefit is you may actually tamponade some of that bleeding by getting that supraglottic airway in. Now, once that airway is secure, now we're really going down the pathway here of critical patients who you're trying to keep alive. That patient in the back of the ambulance, when we got that call in heavy hemorrhagic shock, she was alert and oriented when we got the call, but she kept bleeding, so things progressed, and we'll get back to that. You can, once you have the airway established, pack the mouth. Once that airway's there, you can take rolls of gauze and pack it into that oropharynx. This is us in the emergency department. But if you look on the left-hand side of that screen, those two big rolls of gauze, all of that went into this guy's mouth. Now, you don't see an endotracheal tube sticking out here because if you look carefully, this guy has a tracheostomy, right? So he has an airway. But we packed both of those. And this is not the patient from the box call. This is a different patient who had a massive oropharyngeal bleed. We packed both of those into his mouth, tamponaded the bleeding, kept him alive enough to get him back to the operating room, where they did further resection, ligated vessels, embolized, all of that stuff to keep them alive. You can do that if you have an airway established. If you do any of these things and you get hemostasis and you're feeling, okay, we're good here, patient's looking a little bit better, what I beg of you, which is tempting, but I ask you not to do, is don't peek. If you have hemostasis, don't touch, don't look, don't suction. The last thing you want to do is undo all the work that you've just done to keep this patient alive by suctioning out that clot. So I beg of you, temptation or not, you did it. You saved that patient's life, just drive and get him to the hospital. And that patient's going to get to the hospital. We're going to run that patient, run, no stopping, to the operating room or to the interventional radiology suite. Circling back to our patient, that patient got to our hospital alive. The paramedics did a fantastic job. They did some of the measures that we talked about here. She got to us, bleeding was stopped. She was not intubated. She looked in pretty good shape, right? By some combination of what was done and her own innate clotting, the bleeding stopped and she looked good. But we knew she had a 50% chance that this was just her sentinel bleed and the next one was coming. Like this one was big enough, but we knew the risk of her rebleeding was huge. The patient looked good. The OR was prepped, but she looked good. So things were done in a controlled fashion. She got that second IV. She got some blood. She looked good. She was going to the OR. Her family came in to say hi to her. The patient made a simple request. Well, in the emergency department, she simply wanted to go to the bathroom before going to the OR for her operation. Seemed reasonable. Patient got up and went to the bathroom. No one's quite sure what happened in the bathroom. We don't know if the patient gargled. We don't know if the patient opened her mouth to look in the mirror to see what all this fuss was about. We don't know if just the movement of her neck dislodged a clot. No one knows, but something happened. And she walked out of the bathroom with the clot dislodged and massive amounts of blood coming out of her mouth. At which point the patient was picked up, put back in her gurney, had a massive transfusion event, blood and products just squeezed into this woman. She was intubated and she was run to the operating room where, due to her imminent life threat, she had surgery where they actually opened her neck and ligated her carotid artery on one side, saved her life. So these things happen. They are very dramatic. When it happens to you, you're not going to forget it. When I was preparing this talk, I was kind of looking around at some things and I came across this shirt and it says, "I survived the clot." I'm going to addend this a little bit and I'm going to say, I survived because of the clot. So to drive the point home, once hemostasis is achieved, do everything you can to not disrupt the clot. It's really important. That's what's going to keep the patient alive until they get to definitive care in the operating room. All right, well, we've been talking for about 45 minutes now. I'm just going to sum this up and then gladly want to hear about your experiences and hear any questions with posterior epistaxis, tracheostomy bleeds, or massive oropharyngeal bleeds. With posterior epistaxis, know to recognize it. Know that this is not an anterior bleed. Always look in that posterior oropharynx. Maybe your patient looks good because they're squeezing their nose and no blood's coming out. Look in the back of the throat. Your interventions are going to be ice TXA and packing. Your heroic maneuver is going to be an endotracheal tube with a balloon to try and tamponade those posterior vessels. With massive tracheostomy bleeds, think about that cuff. Overinflate the cuff. That's going to get you where you need to be 85% of the time. Your heroic maneuver is the Utley maneuver with manual compression. This patient on the right is a young person, you can see adolescent, who had her tonsils out. I got this off of her social media. She posted this herself for public consumption. She writes in the social media post, this picture was taken about 10 minutes before I had more bleeding. I had a large IV put into my femoral vein and received a massive transfusion. I went back to the operating room. I read that and I get nervous, even knowing she survived and she wrote it. But it's disconcerting to read that, knowing that this young, otherwise healthy person went through that. Or pharyngeal bleeding, including post-tonsillectomy hemorrhage, TXA, direct pressure, if you can, heroic maneuver here, intubate, and pack around that tube to try and create tamponade and hemostasis. And every single one of these lead to one of two destinations, the OR or IR. Knowing about these halo events, knowing your first steps, knowing your heroic maneuvers, if you're ever put in that position, well, that's going to make you the angel and you're going to get the halo. So thank you for your attention. I really enjoyed talking to you. I would love to hear about your experiences with this. I'm open to any questions or comments that you have.
A couple of questions came in. How quickly after a sentinel bleed will a massive hemorrhage bleed happen?
That is a good question. And the answer to that is, I don't really know. They tend to be in short order, but there's a lot of variation there. So can it happen within minutes? Well, yeah, probably continuation of the same bleed. Can it happen within 24 hours? Yes. And that's why my patient who had that bleed earlier, even though she looked great, we're not sending that patient home. At the minimum, that patient would be admitted to the hospital for watching for 24 hours to make sure that clot really set and was not going to come off, but really getting the patient to the operating room is clearly the safer option.
Another one, do we have different suggestions for BLS crews with no paramedic support, especially for the use of endotracheal tubes and other airways? No, if you can answer that or.
Yeah, that's kind of a tough one for me.
Yeah.
You know what your practice guidelines are. So if you get called, hopefully a BLS ambulance wouldn't get called to a massive, excuse me, hemorrhage event. But if you do, recognizing it is going to be a key thing, and knowing about those sentinel bleeds, because you might get called to an event where there was a sentinel bleed and it stopped. And knowing this information, knowing that these are high-risk bleeds, knowing that you need to get an IV into that patient, even though their vital signs look great, even though they look great, knowing that you need to call ahead and let the ambulance know, and let the hospital know that you're coming, even though the patient looks great. Not allowing, to the best of your ability, or doing your best to convince the patient to not decline transport. Those are all critical interventions that a BLS crew can do. And then if the patient starts to bleed again, you've got to do volume resuscitation. As far as whether or not you can put an endotracheal tube in the nose, I don't want to suggest something that can get anybody in trouble. I'm just saying that's something that I would do if I thought it would save a life.
Awesome. And then a nominate artery bleed with transexamic acid be appropriate, or the
Yes,
flow of
you
blood
can.
too great for the transexamic acid to work?
I'm
Yeah.
sorry, I didn't mean to speak over you. I thought the question was done. Would the blood volume be too great? Possibly, yes. But is it going to hurt? No. You're going to give it IV or IM. By all means, give it. You're not going to harm your patient. Even if it helps a little bit, it's going to help. Yeah. Will it stop tracheonominate artery fistula bleed? Probably not by itself. Will it help? Yeah, it's going to help. Has the potential to help. Well, I'm going to throw this back at you for anyone who feels brave and wants to unmute their mic or turn on their video. Who has had experience with these halo events?
Let me also really fast, I want to comment, and I know there are a number of career or super active paramedics, so please feel free to clarify, but I think all of this, back to Nikki's question about, not having the support to use endotracheal tubes or other airways because they're BLS crews. I think this is all like extraordinary care, right? I don't think any of it is outlined in a protocol that says, oh, next, put your finger in the trachea, right, and compress, right? That's not in a protocol anywhere. So I think that's just close medical consultation and, the care that has to be delivered, you know, at that time.
I did speak to Jenny Geither about some
Yeah.
of this before I
Yeah.
gave this talk.
Thank
And
you.
she said essentially, yeah, it'd probably be reviewed, but if it saved a life, we'd be fine with it. So
That's
I did do my homework a little bit.
That's good. That's really good. I think that that's right.
Seems like the right thing.
Yeah.
Anyone have a halo they want to share? Any brave soul out there in Zoom land?
So I do, unfortunately, but it was in hospital setting, right? So I'm in an OR with a lot of oncology, a lot of ENT procedures, and I have two post-tonsillar hemorrhages that came urgently back to the OR that have scarred me for life. I will never forget their faces.
Yeah, I don't think you forget these halo events when they happen. And again, even the fact that this happened today is unbelievable to me, but it really did. And that patient looked so good. And I thought, my goodness, thank God she followed her discharge instructions that said, you know, go to a hospital if you have bleeding, because she so easily could have stayed home and that could have risked her life. Actually, one of my colleagues, their daughter, adult daughter, had her tonsils out and had a sentinel bleed, and literally had her recurrent bleed as she was wheeling to the operating room to have the tonsillar bed sort of recauterized. When she was after she said goodbye to her mom, like literally wheeling down the hallway to the operating room, the clot let loose. She had her major hemorrhage as she was going into the operating room. Thank God for that. And they were able to get into the operating room, and she's fine from it. So.
One of the attendees asked, are any of these techniques work on burst esophageal varices?
Well, TXA, I would give TXA. As far as compression, no, burst esophageal varices, you're not going to be able to have, you're not going to get your fingers down the esophagus. Those are horrible when those happen. A little out of my ENT domain, but the same general principle. I would give TXA, you know, volume, blood, all of that. But that patient's got to get a tube down their esophagus that has a big balloon on it to compress it. Yeah, arterial bleeding is scary.
Super.
All right. Well,
All right,
thank
all the
you,
accolades.
everyone.
Thank you, Laura. Thank you so much for taking the time and sharing with us. As always, we love having you.
And thank you guys. You know, you guys really do the hard work on the field. I am always amazed when someone comes in intubated with their IVs, and half the time you fix the patients by the time they actually get to me. So I really appreciate the work that you do.
Very
Have a
nice.
good night, everybody.
Good night.